Dr. Lucy Abbott, who is now, we've just going back to the structure of the session, we've had the whole country's landscape, and then we've come down to a system strategic view, and we're now going to actually implementing Frailty and Flow. So I'm going to hand over to you, Lucy, and you will have time for questions for both Lucy and Tanya at the end of Lucy's bit. Thank you.
Lovely. Thank you very much. So yeah, I'm Dr. Lucy Abbott. I'm also a consultant geriatrician. I chair the Frimley Integrated Care System Frailty Network, and I'm also our NHSE South East Region Clinical Advisor for Frailty. So I support trusts and systems across the region with their frailty work. Next slide. So really just going to share today what we have been doing within the Frimley ICS, and we very much right from the beginning. So we started this journey back in 2017, where we've been consistently taking a system approach to frailty, focusing on both proactive care for people living with frailty and reactive care, and also our care home population as well. So I'm going to share some examples of the work we've been doing there, and also finish up with a bit of key learning. Next slide. So this slide essentially shows our vision for people living with frailty across the Frimley system. And essentially, it's exactly what you've already heard about a personalised, holistic approach, recognising that someone living with frailty actually wants to and will hopefully spend the majority of their time living in their usual place of residence. And essentially, we need to have the system leadership and that system oversight, bringing together all of the partners that we need in order to provide that integrated holistic care. And ultimately, we want to provide the right care at the right place, at the right time, by the right person. And essentially, we want to take that proactive approach of keeping people living well. So things that we have in that space at the moment. So of course, as we've already mentioned, it can't be too health focused. You know, we've got social care, we've got voluntary sector, etc. We have a remote monitoring program I'm not going to talk about, but again, that's about monitoring people who are high risk, trying to predict and early deterioration and get in early. We have integrated care teams, that multidisciplinary teams again that will support individuals, and we have geriatricians in reaching into those. And of course, we have our primary and community care and everything that we have set up to support care homes as well. Unfortunately, we all know that it doesn't take much. A minor insult, such as a simple infection or a breakdown in someone's care and support network, can precipitate a frailty crisis, which can then precipitate that 999 call or the need for some kind of emergency health response. And that's when we need to provide a good reactive model of care. So we are hoping that this will be accessed through a single point of access, and that can be used by GPs, social care, community services, etc. And then that comes through to our urgent community response hospital at home service that interfaces with the acute hospital and the front door frailty team and the Frailty SDEC. And then of course there's a really important role for intermediate care and community rehabilitation once people have received their acute care. So that's the kind of overall model. Next slide. And we know that this model must be working. So it's difficult to know which bit of the model has the most impact. But essentially, if you track our frailty data in terms of people that are admitted to Frimley Park Hospital. So you can see, looking at the time, that there was a significant drop during the COVID pandemic. So we knew that fewer older people were coming to hospital at that point. And the other strange dip is when we launched our electronic patient record, EPIC, because we had some problems with our data reporting at that time. But otherwise, you can see that the trend is either flat, and in fact, over the summer looked as if it's almost coming down as well. Whereas with population aging and population growth, we would be expecting that our admissions would be increasing. So we think that by trying to do that left shift and that model of care, that we are having an impact on usage of acute hospital services. Next slide. So in terms of our proactive approach, it sounds very similar actually to the work that is already being done in Southeast London as well. So essentially we have a shared care record, which means that we use the Johns Hopkins tool to proactively identify people with frailty who are at high risk of admission. And that means that, so we can generate lists for our community frailty services, and essentially they can give those people a call and say hello, and people do not like the term frailty, so we say hello, would you like an assessment in order to keep you living well, is how we phrase it. That person then actually has a face-to-face assessment, because we need to make sure that they're suitable for the proactive care programme, and then they go on to have a holistic assessment based on comprehensive geriatric assessment, and that's the tool we know that improves outcomes for older people with frailty. We then do that personalised support planning and interventions to keep them living well, including something called the respect form, which gives recommendations about emergency care if that person were to fall into crisis. And essentially we coordinate the interventions and the support that's required. And the outcomes that we found from that model of care is that if you look at people's A&E activities and admissions before and after the proactive interventions, we've managed to reduce it by 30% for that cohort of people. And of course, polypharmacy review is a really important part of those proactive interventions, which can actually result in real financial savings. In the interest of time, I'm going to skip through the next few slides because there's some more detail there about what the model actually looks like if you want to read about it. So then when someone falls into a frailty crisis, we then have an urgent community response and hospital at home service that can respond to people in crisis. If we go on to the next slide. Yes, this is just some, as you can imagine, the patients are very grateful for the proactive care that they receive. And essentially hospital at home is about bringing that acute level care to the patient's home when they fall into frailty crisis and become unwell. And essentially we've got lots of kit that we take with us, so point of care testing, we can get blood results, we can do ECGs, we've got a bladder scanner, we can give oxygen, we can give nebulizers. And essentially we use our electronic patient records in order to be able to document and to order tests, investigations, prescribe, and that enables us to kind of communicate across the acute and community boundaries. Next slide. If we go on again, there's just some more details about what we can offer. The critical thing is that the hospital at home service can be accessed by any number of referrers. So we'll take referrals from 999, GPs, community services, etc., which means that we can rapidly get to that person within 2 hours. And we work very closely with our ambulance provider, and this means that actually we may even go and respond to a patient before the ambulance crew has been dispatched. So we're also helping to take the pressure off the ambulance service, as well as primary care colleagues, etc. And again, there's just some outcomes here about showing actually how effective the service is. So people, as you can imagine, absolutely love the service. They're at home, they get better quicker with their supported by their relatives and their normal carers. And the other thing is that staff find it very satisfying to work in these services because it's a really good model of care. Next slide. And again, this just proves sort of how many patients we're seeing and that we do actually genuinely keep people out of hospital, because I think there's some challenge about virtual wards as to whether perhaps you see people for a short time and then they end up in hospital anyway. But this shows that we do, with appropriate escalation planning, appropriate care and treatment, that we are able to keep people out of hospital. Next slide. Next slide. And then just a couple, and again, as I say, we get fantastic patient feedback. If we go on to the next slide. So yeah, just a couple of things about care homes. So again, we have a really robust care home support model within the system. So this is led from system level, but also with community services and primary care as well. And essentially we do a lot of education with our care homes. We have a regular care homes forum, and things that we focused on recently: oral care, nutrition, falls, delirium, dementia, recognising end of life, and the Restored 2 tool as well. We've made sure that all of our care homes have NHS email addresses so that they can communicate easily with the GPs. And of course, we now have the weekly care home ward rounds as well. The remote monitoring I've already mentioned. And then again, we've been using the respect form to make sure that residents have clear escalation plans, and that ideally they receive that hospital at home urgent community response in the first instance, rather than needing to come to hospital. And if they do need to come to hospital, then we've got our acute frailty service at the front door in order to get them back to their care home as quickly as possible. Next slide. And this is just to show that we've been tracking some of our care home data. And again, this gives you data from this winter. So you would be anticipating people would be sicker over the winter period. We'd be seeing more 999 calls, more ED attendances and admissions. And in fact, we haven't been seeing that over this winter, which suggests that we are able to provide that community-based approach instead. And again, just the next couple of slides just show some of the care homes data that we've been able to track, and we will be taking forward, because, for example, I've blocked out the names for IG, but we know exactly, you can see on the box on the far right there, we know how many beds the care homes have, and then we can also see how many 999 calls, how many ED attendances we're getting from each care home, and then we can actually do some specific work to kind of support the residents in those care homes as required. So in terms of our key learning, if we just go on to the final slide, really the key to all of this, to sort of the achievements that we've made, is taking that whole system approach. So no one provider can do this in isolation. It's about working together and having a very wide network of stakeholders at our frailty group, from public health through to the acute trust. Obviously, people have mentioned that there's loads of kind of national policy from NHS England and guidance from the BGS, so making sure that we've been using that to really inform the services. And obviously there isn't lots more money, there's not lots more people, workforce, but by collaborating, integrating and avoiding duplication, we're managing to kind of do things with actually very limited resource. Having a shared care record and digital integration across our community services and primary care have been really critical to supporting this. And ultimately, we need to make sure that our workforce has received appropriate sort of training and education to deliver this model of care. So it's a bit of a whistle-stop tour of the Frimley system, but that gives you a bit of an idea of what we've been doing.
Thank you so much, Lucy. So you've had the national landscape, you've had a system overview with strategy and pulling together the key and important actors, and then you've had an example of implementation in Frimley with the evidence base around its value. So I'm sure there are questions for either Tanya, Lucy, or for both of them. So I'll open it up now. John.
Thank you, Dagny. Question for Lucy, if I may. I was fascinated in the frailty assessments that you offer to people when you're worried about them or there's cause for concern. I just wonder how you manage the reaction that you get from either individuals or families to this suggestion that they may be deteriorating.
Yeah, and that's why. So when we started off, we rather naively did phone them and say, would you like a frailty assessment? And that didn't mean anything to people, and they didn't like the term at all, which is why we then phone and we said, would you like an assessment to keep you living well? Because actually, or keep you independent, because that's actually what matters to people. And the other thing is that we are effectively cold calling people from a list. and there is some clinical validation that obviously happens before we phone them, but it is possible that that person, that, you know, how they appear from the coding on the electronic record, it isn't, you know, then doesn't actually, you know, correlate with the actual person, so because it's not 100%. So that's what we talk about, keeping people living well, keeping people independent, and that does mean things to people. We do have a few people that think it's a spam call, that it's some kind of scam. So again, you know, often, so the people who make those initial calls, we give them a number, and then we say, if you want to phone us back and it is, you know, the primary care network or whatever, you know, please do. And just to prove that we are, you know, we are who we are, we've got everything up on the website, so we can point people in that direction. We've got a patient leaflet as well that we can send out. But there's a little bit of learning, and that's something that I would share if anyone was setting this up, about how you do kind of proactively approach people, sort of to get them engaged in this. But once they've had the assessment, and then they tell their friends, and so on and so forth. So yeah.
Thank you, Lucy. And Christopher, would you like to ask a question?
Hi, Christopher Tibbs, Regional Medical Director South East. It's really a comment. As many of you know, I looked after my 102-year-old father until he died in October. And although we didn't have the benefit of the Frimley Frailty service, we had the one from Royal Surrey. And I think it is very interesting to reflect how important it is to break the mold of grandpa's ill, let's take him to hospital, and to make sure that in advertising all the excellent work that you do, Lucy, and the other frailty services around the South East, that we don't overload the system. And I wondered if you felt that you have enough resource put into your service to be able to really work at keeping patients at home. And this, of course, is in the context of all the news about shrinking the NHS and making it more efficient, because I do genuinely believe that this is one of the ways that we can make a massive impact on resource expenditure. And I just wondered how you were getting on with your resourcing.
Lucy, I'm going to get you to answer it, and then Tanya, I'd really like your sort of system overview of it as well. Thank you, Lucy.
Yeah, so I think because we've taken that system oversight, the system has made a positive decision to invest in frailty services. And so obviously when we had our Ageing Well funding, that was all ploughed into hospital at home and so on and so forth. And I think if you look at the sort of staff feedback on the slides, actually shifting people to do proactive care, they kind of realised that a lot of the time they were doing the reactive stuff, and actually if they shifted and did the proactive stuff, they wouldn't be doing the reactive stuff. So again, it's just about changing mindsets, and you've got lots of people out there already, intermediate care, community matrons, you know, the front door frailty service, that actually you can coordinate some of these services in a different way without actually needing more investment to provide this model of care as part of the work that they are doing.
Thank you. And Tanya?
Yeah, there are different boroughs are trying it different ways. You can try and create a specific resource, and that's helpful. And I think in South East London, we're in a slightly different position to Frimley, in that we already had quite a well-established hospital at home service, which if you don't have is a big gap. But I think, the approach we're really taking is it's about influencing change amongst existing services in the way that we work, rather than creating massive new teams. We've got the people, we've got the expertise, and it's about how do we use that collective resource more efficiently. And some of that comes down to my comment about we've got lots of cross-cutting skills across different disciplines and different professions, and it's about us maximising us to our, the limit of our license, to in order to deliver more for the same numbers, and perhaps also accepting slightly less perfectionisms on an individual level, to say, okay, how do we reach more? And actually doing good for all is better than doing perfect for a smaller group.
I love that. What a fabulous way to end that Q&A. Thank you very much, Tanya and Lucy, for your presentations. And finally, we're going to move on to In fact, it leads on from a couple of questions about can pharmacists refer in, the issue around polypharmacy and the harm that comes from it. So I'm going to ask Nigel Beckett